Hi everyone, it's Dr. Andrew Orr here today, and we're here as part of Endometriosis Awareness Month, and I'm here with the amazing Dr. Glenn Sterling. Thank you for coming on and doing this with us.
It's an absolute pleasure, Andrew. No drama.
For those that don't know who Dr. Sterling is, which I highly doubt it, he is very well renowned for helping people with reproductive medicine, fertility. He's also an advanced trained surgeon. He does a lot of work with women with endometriosis, but also helps a lot of couples be able to conceive. So what's one of the things that you could say to a woman that's experiencing period pain and symptoms like IVF symptoms and sitting at home thinking that it's normal?
Oh, look, I think at the end of the day, the proof's in the pudding. I mean, we have, even in those teenage girls that have those sort of symptoms, the literature would indicate that 50% of those girls have problems. I mean, one of the issues is that you always ask these girls that, you're talking about the pain, but they always in the back of their head, it's always the fertility is something that they worry about. So you see a lot of girls and a lot of mums come with their daughters where doctors have been reluctant to do anything to try and find out, A, what the problem is. In other words, get a proper diagnosis, and B, address these issues, not only because it's in the back of the head of the little lass that's sitting in front of you with the pain about reproduction, but also mums wondering about, gee, are we going to end up having grandkids here? So I think that the thing that often brings the girls forward is the pain, but the worry in the back of the head is their fertility, I suppose. So I think there's a lot of reluctance on the part of surgeons not to have a look inside girls' tummies to see what on earth's going on. There's one girl I only did a couple of weeks ago that, we thought, no, she's got a bit of pain. It's probably unlikely to be endometriosis. I had a look inside her tummy, and everywhere there was this sort of appearance of, gee, I'm not sure whether that's endometriosis or not. I took about 5-7 biopsies, and every one of them came back positive, which even surprises me. So I think this notion that that we dismiss symptoms and we treat them with Panadol, and that that inflammatory response they get in the pelvis can be very damaging in terms of pain and its physical destruction it does over the fullness of time. So I think we need to be very cautious and to make a correct diagnosis and act on it, not only for the poor girl's comfort, but also for a long-term well-being. So
yeah, and that's one thing we always say, because the stats show that a lot of women are missed and dismissed, and it can be up to 10 years or more for diagnosis. And one of the other things is that young girls, like teenage girls, aren't too young to have it, and we see some parents are reluctant, or the wait and see approach. But as you and I would say to them, well, do you want to have grandkids later on, and do you want to see your daughter have kids later on as well? So it's very, very important.
It's interesting that even when you get girls that have no symptoms, immediate symptoms, I would call them, things like the painful intercourse, painful periods, and so on, we find that girls that describe none of those issues, when they're trying to fall pregnant, and we go and look for reasons as to why they might not fall pregnant by laparoscoping them, 50% of these girls that are trying to fall pregnant have endometriosis, which of course is one of the most written about and researched topics associated with infertility. And so I think that a lot of girls, they have it undiagnosed and they don't really understand why they're not falling pregnant. Nobody does. And then suddenly some genius comes along and says, hey, let's go and have a look inside your tummy. And they've been going through IVF and all the rest of it. And you have a look, you get rid of the endometriosis, and honestly, they don't need to be doing IVF. They just need to get home and get busy once you've sorted out what the problem is. So it's an issue. It's almost like a silent issue for a lot of girls that I see, as well as one that can be destructive from a pain and psychological point of view. But it's sometimes almost like a silent major contributor to a problem that girls are suffering from psychologically. Do you know what I mean? So it's really important to sort of get in there and sort it out for them. And once they do have a diagnosis, I think life becomes a lot simpler, because they're complaining and they're upset about stuff without really knowing. But when you make a diagnosis, you can, they can be reassured that, hey, I'm not crazy, and there actually is something real there that's causing problem. Now, on the other hand, if you do go and laparoscope somebody and they have pain and you find nothing and your biopsies are all negative, well, again, you can reassure them and say, look, we couldn't find anything, but I guess it's like a box, right? You can look at the outside and these girls, you'd see no endometriosis, but it doesn't mean there's not something going on underneath. But at least you can reassure them that, look, it looks normal, there's no inflammation, your fertility is going to be good. And once you do that and reassure people, you'd be surprised how often they'll focus on other things, get on with life, and things tend to settle down. So actually, the positive and the negative can be very beneficial to them.
You brought up a really interesting point there about sometimes you'll go in and you won't find anything. And I actually had a case with a surgeon over in Perth recently that, went in, you're quite 100% sure you're going to find endometriosis, didn't find it. Actually ended up asking for a review of the pathology, the histology. And then after the review, first of all, he said, well, no, the first one said, no, there's no endometriosis. The second one on review actually came back and said, yes, there is endometriosis there. So it's quite interesting how, sometimes you might go in too early, sometimes it might not have expressed yet, but I think early intervention's the key to endometriosis too, like you said, that early management and, find whether it's there or not, and helping these women, get a diagnosis is really important.
Agreed.
Yeah.
They can certainly change the direction of how you investigate, treat, and all the rest of it, right? So it's like the classic. I mean, you can put them on the pill thinking that it's endometriosis, stop the periods, hey, happy days, right? But even if you get a lasso where you do that and you pretty much eliminate the painful periods, you still don't eliminate the disease or make a diagnosis of what the problem is. And so as time goes by, that can have a detrimental effect upon the anatomy, but also psychologically, they got this pain. You disguise it, if you like, by using the pill, which is fine. I don't have any issue with that, but they still don't understand exactly what the problem is. I think a much better principle would be to, take a history, examine them, get a diagnosis, biopsy, whatever, and then treat people. I think that by following the basic steps, I think in the long term, you're always going to be better off in terms of actually knowing what you're dealing with, right?
Yeah, this is it. And you'd probably see, what are the long-term consequences of unmanaged endometriosis? Because I'm sure you've gone in and seen women that are pretty much, their pelvis is pretty much obliterated with it, which it can happen.
There's when you operate on people, there's varying degrees of damage that an underlying pathology can do. If you were to ask somebody which is the most damaging, is it cancer? Is it endometriosis? Is it radiation? Or would it be, factors like that? They're probably the most difficult people to operate on after they have been treated would probably be people that have been irradiated because they get terrible inflammation. Yeah. The easiest people to work on are probably cancer patients because, you don't get lack of definition in terms of your planes. But endometriosis isn't far off the radiation because you've got this underlying inflammatory, and some people that, they can end up with terrible, terrible tummies where there's adhesions, scar tissue everywhere. You can't tell the difference between the anatomy of bowel, ovaries, bladder. You've got no idea what's going on. The anatomy is so distorted and so scarred up, you don't even know what organism or what organ it is you're trying to get dissected away so you can see what on earth's going on. So the complexity of endometriosis can be, the scale of it is enormous. So you can go in, have a look, and you might see a spot, which is great. You dig it off, get the histology, fantastic. Rest of the anatomy is okay, right up to the other end of it where, you need a general surgeon to try and help you sort out the anatomy, or urologist or whoever, before you can actually have any idea what you're dealing with, even to begin with, right? So, yeah. But the surgery is, I got to tell you, it's nothing that I put my hand up to volunteer for as a difficult endometriosis case. They are hard work, and the anatomy can be very challenging, I can assure you. And, a lot of girls, they end up having bits of bowel removed and that sort of thing because it's so entangled and caught up in the adhesions, endometriosis, all the rest of it. So they can be very difficult people to operate on, and the pathology and the inflammation that goes on for years and years is so damaging. It can be an absolute nightmare, and you just wish you were home having a Chardonnay rather than operating for hours on these people. But you got to do what you got to do, right?
Yeah, this is it, and this is it gets back to again, that early intervention. If they'd come in younger and you've got them younger, you're not going to get all this happening.
No.
And I think you bring up a very good point too. It's not just the physiological symptoms; it's the mental and emotional symptoms that these women are going through, and some of them on the brink of, suicide and all kinds of things, which is quite sad.
Oh, for sure, definitely.
So what a lot of people have misperceptions about surgery though. This is one of the big things that I always have to get past. And there's been some great advancements in surgery, like with laparoscopes, and now laparoscopes even thinner than what they were before. But what are the advancements? What does that mean for women these days? In terms of recovery, their treatment, their management. How is it? How is all these advancements helping women now?
Well, I think that as time goes by, the real, the advances have really been from an anaesthetic point of view in terms of they're easier to put to sleep, easier to wake up when you have a easy transition in and out of the anaesthetic. People feel better afterwards, go home, less nauseous, experience all that sort of stuff. So I think anaesthesia is a big step forward. In terms of the surgery itself, all of our instruments are getting smaller and smaller, but the quality of the images that we get when we're inside somebody's tummy is getting better and better. So it's becoming easier from a technical point of view to do. The incision marks are getting, the incisions are getting smaller and smaller, and your surgery isn't being compromised at all in terms of what you're capable of doing. I think we need to be a little bit careful in that. At the moment, there's tending to be this move towards what we call robotic surgery, and I think for some specialties it's a great asset. For example, guys that are having their prostate removed, that's a real, that's proven to be a real good thing for laparoscopic surgery. And one of the big advantages of that, of course, is that the guy doesn't lose his function in terms of erectile function and ejaculation and so on. So they can maintain that and have their prostate removed because the robot allows you to be, the technical side of things, and your precision is much greater. Now, when you're talking about laparoscopic surgery for somebody with investigation or for removal of simple sort of endometriosis, a lot of people are kind of encouraging the robot. And it's a little bit like laser was back in the 90s and so on, that, laser, it's a buzzword, everyone loves it. Gee, I better have some laser. It sounds like it's the best thing for me on earth. Yeah. When in actual fact, all laser is an energy source, right? So whether or not you use the scissors, diathermy, whatever your energy source is, you're basically doing the same operation, which is removing endometriosis. The problem with robotic surgery is there's a couple of things you need to keep in the back of your mind if people are trying to sell robotic surgery to you. It takes a lot longer.
Yeah.
Now, whenever you're operating on people and it takes a lot longer, there is an inherent risk to that patient that they are asleep longer. The anesthetic risk increases. The problems with expanding the lungs and getting lung into the air is greater. They're going to be on the table longer. They don't move, so they've got a greater risk of DVT, pulmonary embolus, and the longer you're on an operating table, the greater the risk of infection. So the anesthetic time is significantly increased if you're using robotic surgery than if you're not. The other thing is, with robotic surgery, you do have to have a number of incisions, and often those incisions can build up to an incision, if you added them all up, to be the same sort of length as a laparotomy. And a laparotomy, of course, where you're opening somebody's tummy up rather than doing keyhole surgery. So I would just caution people that I think there's a group of surgeons out there that want to promote the robotic surgery because it's cool, it's hip,
it's the buzzword.
That's right, it's the buzz. But in actual fact, you pay through your nose for it, whether that be financially, physically, or complications of the surgery. So just take an ounce of caution from that. Your basic laparoscopic surgery that we've all done for a long time, our better equipment, our more efficient way that we do it minimises the risk of all that to you. Most procedures are pretty quick. And like I say, when you get into complicated things, you have no choice. But I don't think you want to make a situation complicated to begin with by doing robotic surgery when it doesn't need to be complicated.
Yeah. And what would you say to, we know that, hysterectomy doesn't cure endometriosis, but it is an option for women that have done everything. They've gone on progestins, they've been on painkillers, they've done everything they can. How could hysterectomy help those women? Because it's something that's not often talked about either.
Look, I mean, it can be a huge solution to a huge problem. I think what we need to sort of understand is a lot of girls are concerned about the fact that we're going to remove their ovaries at the same time as the uterus, and that's not simply not the case. The majority of women I remove their uterus on are girls that are premenopausal, and I'm very reluctant to remove ovaries because they produce, they produce hormone. They play a very significant role in terms of physical well-being with girls, and so I'm very reluctant to remove ovaries. On the other hand, tubes in the last 5 years, when we do remove the uterus, we tend to remove the tubes now because you decrease the incidence of ovarian cancer by 50%. In other words, a lot of ovarian cancers that were diagnosed as such previously, in actual fact, originate in the tube. So removing the tube decreases your incidence of ovarian cancer by 50%. And because you're going to be removing the uterus, most girls are actually pretty cool with that because it serves no function other than get you into trouble. Yeah. So a major part of endometriosis and the symptoms associated with endometriosis is the uterus, right? Yeah. So when girls are having their period, they get pain. They, at the top of the uterus, at the top of the vagina, where the uterus and cervix is, causes painful intercourse. So the reality is if you remove a uterus, you take away periods, you take away the inconvenience of pads, tampons, the cost of that, the pain of the period. And although it will not necessarily solve all the pain that girls are experiencing with their endometriosis or associated issues, if you like, with it, pain running down legs and all the rest of it, yeah, by removing a significant amount of the symptoms that they have, it's like a relief valve that's enough to take the pressure off it such that the pain or the discomfort or the remaining issues that they have seem not to be as magnified as what they otherwise might, which in turn will allow them to sort of get on with their life and tend to forget about it more, the residual discomfort, and so they're able to cope with it a lot better. So I agree that removing the uterus isn't the solution. However, with a lot of girls, by doing it, you actually give them that relief valve so that the situation isn't as bad as what it was, thereby allowing people to be able to get a lot of quality of life back and subsequently soldier on and these other things tend to resolve, even though, as you know, if you've got endometriotic tissue and ovaries functioning, it can be an issue, but gee, it's much less than what it was. And of course, don't forget that when you're removing the uterus and the tubes, that source of endometriosis, the retrograde bleeding from the uterus up in the pelvis, no longer occurs. Yeah. So new disease or the development of new endometriotic islands of tissue probably don't develop, and subsequently that keeps them out of trouble in the long term as well.
That's right. And look, a lot of women also have adenomyosis and don't realise they've got it too. That's the other bit, and they've got the heavy menstrual bleeding, and yes, hysterectomy can be it's a great solution to that. I mean, they get their lives back. There's no doubt about it. Most women that come to see you or I, the one thing they always say, I should have done that 10 years ago because now I'm not anemic, I'm not, struggling.
Well, I mean, you think about it, Andrew. I mean, there's no longer anemia. You turn the tap off in terms of losing blood. You become stronger. They feel a lot better in themselves, much less iron deficiency. There's no need to go and buy tampons and pads, which cost the earth. They can have intercourse whenever they want to, but often girls will elect not to tell their husbands that because they just need a little spell each month, I suppose. I don't know. And when I say to them after I do the hysterectomy, I always say no intercourse for 6 weeks, and they go, "Okay, I'll tell my husband 6 months. That's not a problem." So there's that, but girls don't need to have their smears anymore if they don't have any pre-existing problems. So no smears. No pap smears, no tampons, no pads, intercourse whenever you want to, still maintain your ovaries, still the ovarian function. And the other thing that people forget about is that if you go through menopause and you are not producing enough estrogen yourself from your fat tissue, which is a good source of estrogen, if they don't, and they're slim girls, if they need to take HRT, then there's no need to have the progesterone component of that HRT after they go through menopause. And so subsequently their risk of those other complications of HRT are not there because they simply take estrogen. They don't need the combined estrogen and progesterone, which has been the source of problems over the years. So if you've got a girl in her early 40s, or in her 40s and are talking about a hysterectomy, you've got to also mention that post-menopause, there's going to be a big advantage. You'll either, if you need estrogen, you can take it safely for as long as you want, which is something that it's a complication that comes after menopause for a lot of girls, that they need to think, gee, I've still got my uterus. How do I manage this safely? How long do I take HRT? Am I going to be at higher risk of breast cancer? All that? Well, you don't need to worry about that as much, because there's no uterus to complicate the situation. And similarly, in a similar vein, you get women that when they go through menopause, and if they're big girls, well, they have their uterus, they produce a lot of estrogen, and that just stimulates the endometrium. And so this is where a lot of endometrial cancers come from, is that they have the unopposed estrogen coming from the fat tissue. Post-menopausal, they're not having their periods anymore. The cells build up and up and up, and after a while it turns into uterine cancer. So it can be an advantage in that regard. And, you know, for big girls that produce a lot of estrogen, it can be a concern.
Yeah, and this is something that we don't often talk about too, because all that fat tissue, as we refer to them now as like obestrogens, really, it is a bit of a problem. And that's an interesting point that you brought up.
So I tell girls, you know, to make them aware, there's three sorts of estrogen. There's E1, E2, E3. E1 comes from fat. E2 comes from the ovary, and E3 is estriol, which comes from the fetus, which we would hope at the age of, you know, 50 or something rather, there's not much of that floating around. So at the end of the day, if girls, once their ovaries or estradiol, E2 stops functioning, well, they've still got the E1. But if you've got a very slim girl, or you know, girls that have a lower BMI, well, you know, they're going to be, when they get to menopause, they'll feel it. So they may well need to, they're at higher risk of using estrogen post-menopause, so they might be people that might be more inclined to, you know, remove the uterus as an issue earlier on.
Yeah. What do you reckon are the biggest misperception with endo, though? Like, if someone's out there listening at this moment, a woman sitting at home, what are the biggest misperceptions that you hear or you see?
Oh, that it's an easy disease to sort out. I also think that, you know, it can be very difficult. I mean, it can go on for years and years, and it can start really young. Yeah. I think that people think that you can only have endometriosis and something can be done about in your 20s or in your 30s. Yeah. That's not true. I think it's much younger. I think that people think that it's easy to operate on all the time. It is not easy to operate on. Sometimes you can get caught really bad, where you think it's going to be easy, but it's an absolute nightmare. So it's very difficult to predict what's going to happen inside somebody's tummy. Yeah. A lot of people think that, well, I don't have any symptoms. How can I have endometriosis affecting my chance of falling pregnant? Well, 50% of girls that have no other symptoms apart from the fact they can't fall pregnant have endometriosis. So I think that's another common misconception. Yeah. What else was I going to say? Oh, gee whiz, I can't recall. There was something else I was going to say there. But oh, that's right. The other one is that you have a lot of girls who, when they are diagnosed with endometriosis, they believe that they need to come back and you know, after they've had their kids or whatever, they have no symptoms, but they say, oh, look, I've got endometriosis. It's the time that I had a laparoscopy again. I think a lot of people need to remember that endometriosis is something you do. You treat endometriosis based on the symptoms. Right. Cancer, you treat the disease. Endometriosis, you treat the symptoms. So you can have a belly full of endometriosis, and if you're cruising along beautifully, falling pregnant all the time, no painful intercourse, no painful periods, no abnormal bleeding, you don't worry about it. On the other hand, if you have cancer, even a little bit of it, you do something about it. So you treat the disease. With endometriosis, you treat the symptoms. Yeah. So if, for example, you have some girl that can't fall pregnant because she has endometriosis, you laparoscope and remove it, she falls pregnant. Well, then down the track, she might develop endometriosis again, but she might not be wanting to fall pregnant. So treat the symptoms, not the disease.
Yeah, this is it. And that's what I say to a lot of women that are out there. The main aim really is to get them asymptomatic if you can, because that's what it's all about. If we can take your symptoms away, well, then you don't have to worry. You've still got endo, but that's the main aim of everything.
Correct. That's it.
Yeah.
And I think that there's probably a little bit too much intervention unnecessarily. Yeah. And I think that we need to keep in mind that, you know, people want their symptoms treated, not their disease in this particular circumstance.
Absolutely. Some really good advice there. Very, very, very good advice. Well, Dr. Sterling, thank you very much for joining us today, and thank you for being part of the endometriosis awareness.
You're more than welcome.
If people do want to find Dr. Sterling, you can go to Life Fertility. It's lifefertility.com.au. Is that correct?
I think you're all over it, Andrew.
And you can call on 0736 063131. Or you can also email reception@lifefertility.com.au. And yeah, we thank you very much for what you do for women, because let's face it, without people like yourself, a lot of women wouldn't be able to conceive.
And I just sort of say to people as well that, don't underestimate the value of, adjuvant treatment in forms of what Andrew offers is, in terms of treating your symptoms. And we said this is a symptomatic disease, not a disease that requires treatment of the disease as such. So, if you've got pain, if you've got painful periods, there's a lot of stuff that can be done that doesn't necessarily involve surgery. So Andrew pulls out his magic needles and throws them like, he's down at the pub, like for, what do they call it? Acupuncture and all that sort of stuff. So all that stuff, a lot of people get benefit out of it. So there's different ways to approach pain and discomfort and that, rather than just necessarily surgery or drugs. You've got to make, we're treating a whole person here. We're not treating just an organism that you give pain relief or chop them open. So, make sure that you get good advice from as many people as you can around you. And at the end of the day, if you're struggling, I'll give you the best advice there is.
But it is true, like endo does need a multimodality approach, a bit of everything.
Correct.
And we do know, despite the best surgical and medical interventions, that sometimes women are still in pain. So it is looking at everything from pelvic floor physio to things like acupuncture. There's herbal medicines, there's exercise, there's all kinds of things you can do alongside
like even stuff like down dogs and all that sort of stuff.
Yoga, yes.
It probably helps people. You just got to get in there and do that down dog thing. You know what I'm saying?
And now there's research on it as well. So
down dogs, is there?
Yeah, through UNSW did a big research on
yoga. Did they really? Wow, that's interesting. Very good. Oh, happy days.
Excellent. Well,
thank you. We got to do the Cobra. That's the other one.
That's it.
That's the one.
I'm glad you're all over it.
Don't you worry about a thing. Andrew.
And the one thing I always say to people when they're going to have surgery with you, they are assured to have a laugh on the table as well. And I think that's really important as well, because one of the things my daughter said to me, the last thing that when she went under, you said to her, "Julia, tell me when you're asleep." And she said, "I remember."
I'll usually say, let me know when you're asleep and we'll get underway. And they always go, yeah, no problem.
But there's even research on that if you can make people laugh a little bit more happy before surgery, it actually improves their post-surgical outcomes. So.
Correct.
All right, Dr. Stelling, thank you very much for joining us. And it's always a pleasure, and it's always good to work along with you and help.
And same in return, Andrew. Thank you for your time.
Thank you, mate.